Hello, my name is Srinivas. I'm a GU medical oncologist at Stanford, and I'm going to cover the topic of immunotherapy in prostate cancer. While we have many FDA approved therapeutics in immunotherapy for various malignancies, its entry into prostate cancer has been somewhat challenging. And much of it has to do with the microenvironment being considered cold. So we have a balance between immune stimulatory agents as well as immunosuppressive factors that contribute to response to therapy. Unfortunately, in prostate cancer, the immunosuppressive features clearly balance the immune stimulating factors. We know that factors such as high tumor mutational burden, having a microsatellite instability, having HRR defects all contribute to increased responsiveness to immunotherapy. Unfortunately, their presence in prostate cancer is quite low. In my topic today, I'm going to cover vaccines, immune checkpoint inhibitors and their use in prostate cancer, or at least the trials to date. I will cover T cell engagers such as BiTE therapy and CAR T, and also include antibody drug conjugates as well as radioligand theranostics. So the initial success in prostate cancer was seen with Sipuleucel T. In fact, it's the first therapeutic vaccine approved in any solid tumor was in prostate cancer. This was taking patients' dendritic cells and harvesting it with prostatic acid phosphatase along with GM-CSF, making it into a vaccine and injecting it back into the patient. This was FDA approved now almost 2 decades ago, based on the IMPACT trial, which was a large phase 3 trial in metastatic castrate-resistant disease, where there was an improvement in overall survival of about 4 months. Since then, there have been a series of failed trials. Vaccines include many different kinds. So cell-based vaccine, of which you have autologous or allogeneic. Autologous example is Sipuleucel T, and the allogeneic vaccines include GVAX, which was a large phase 3 trial, which unfortunately was negative. There are other types of vaccines. So there are peptide-based vaccines, which are in much earlier phase of development. We have viral and bacterial-based vaccines. A large trial using pox virus was studied in the phase 3 ProstVac trial, looking at pox virus with 3 co-stimulatory molecules. Unfortunately, was a negative trial. And then there are both bacterial, RNA-based vaccines and DNA-based vaccines, all in very early stages of development. Moving on to antibodies. So CTLA-4 antibody is FDA approved in many malignancies, including melanoma and in kidney cancer. It was early in its development, was studied in prostate cancer. Now a trial that was published more than a decade ago, looking at ipilimumab in combination with radiation. The initial trials, as you can see in the Kaplan-Meier on the left, was negative, where there was the curves crossed each other. And however, interestingly, with longer term follow-up, there was a paper published in 2021 showing that there was improvement in overall survival favoring ipilimumab. Now, checkpoint inhibitors, again, as I said in the beginning of my talk, while it's been FDA approved in many, many indications in oncology, its entry into prostate cancer has been challenging, and it's not for lack of trying. So checkpoint inhibitors have been studied as monotherapy, and for the most part have been negative. However, there are some responders with pretty deep response, but the majority have been negative, and we clearly need biomarkers to identify who these patients are who are having this high response. Checkpoint inhibitors have been now combined with many, many drugs such as PARP inhibitors, with chemotherapy, with TKIs such as cabozantinib, with novel hormonal therapies such as enzalutamide in the Ambassador trial, with radionuclides such as lutetium-177, as well as with radiation. Again, overall, many of these trials are ongoing. I'm going to focus on just a few examples. So the first one is the Cosmic 021 study. The Cosmic 021 trial was looking at a PD-L1 antibody, atezolizumab, in combination with cabozantinib and VEGF inhibitor. It was a single-arm trial looking at 132 patients, and the endpoint of this trial was looking at RECIST-based measurement. And you can see that the waterfall plot overall showing that a large number of patients had some decrease in their measurable disease. This was irrespective of whether they were PD-L1 positive or not. And responses were seen both in patients with visceral metastasis as well as those with nodal disease. Based on the results of Cosmic 021, this has now moved on to a phase 3 trial called CONTACT-02, which is a randomized trial looking at atezolizumab with cabozantinib versus the second-line novel hormonal therapy. The trial has completed its accrual and results are awaited. Wanted to also share an example of a combination of pembrolizumab, a checkpoint inhibitor, in combination with PSMA lutetium-177. This was a single-arm trial, an impressive PSA 50 response of 73%, and toxicities were consistent with what we know about the single agents. Again, a large phase 3 trial is in progress. Want to move on to antibody drug conjugates. This class of drugs have been very successful in many cancers, including Hodgkin's, breast cancer, and in bladder cancer. And the concept here is having a target, having an antibody that targets it, and have it linked with a payload, which is a toxin. So there are many of these antibody drug conjugates as examples being studied in prostate cancer. I've highlighted a few up here, including sacituzumab, which targets TROP2, a drug called ARX517, which targets PSMA, and there are targets with CD46 as well as B7H3. Hopefully, just as these drugs have been successful in other cancers, we should see some positive studies in prostate cancer as well. Want to give brief examples of BiTE therapies. So these are bispecific T cell engagers. Again, you have targets with PSMA, with glypican-1, ADAM17, as well as STEAP1. These are all ongoing studies with very early results not available as yet. Finally, I want to wrap up by talking about CAR-T. Again, CAR-T approved in hematologic malignancies, but being studied in prostate cancer. Again, really early, both targeting PSMA as well as PSCA. So I want to conclude that prostate cancer is considered a cold tumor. Unfortunately, there's been a paucity of approved drugs. We have many negative phase 3 studies to date. There are combination strategies are being explored, perhaps selecting patients with minimum burden, as was seen with sipuleucel T, may be a strategy, but there are clearly challenges and opportunities to benefit a larger group of patients. Fortunately, there are numerous trials ongoing with combinations as well as new targets. Thank you. I'm happy to take any questions.